Thank you for staying. I'm from University of São Paulo. There I work as a clinical instructor. And also I work with Mary Zanarini in her lab. And I'm really glad now to have like two Brazilians with me. We are the Brazilian trio, Marcelo and Marcos. And I believe that this kind of initiatives like from Mary Zanarini are very important to build bridges for developing countries, helping people who suffer from BPD. That's a very important thing, and we are very glad with the opportunities we had here. And today I'm going to talk about the dissociative experience of adolescents with personality disorder. I believe that's a very important topic to understand. First, I'll say some things about the dissociation. Dissociation is a problem of the process of information and leads to many problems. The definition of the DSM-5 is about the discontinuity of the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. So when you have this kind of problems in processing, between the superior regions of the brain, like the prefrontal cortex, you have some problems, some kinds of dissociation. And sometimes you can have like very low levels of dissociation, like being absorbed reading a book, or very severe ways of getting dissociated, like not recognizing your own body. That brings lots of suffering for the persons who are affected with that. So it has adaptative for a short term. The dissociation is important for a short term for avoiding aversive emotional states. When you have no ways to skip some aversive situations, sometimes dissociation can work very well. The problem, you have like a disconnection with the environment and with yourself by the problems of the processing of this information. So we get like neurocognitive disruptions because you can process information. So it's really hard to monitor reality when you don't look at the reality in an integrated way. It's really hard because you have the very big sensation of losing control. This might dysregulation our emotions as well. We know how important it is for adolescents to be connected, to have social affiliation. How it's hard to deal with shame even for adolescents without BPD. Imagine for patients who are dissociated, the high levels of guilty and anger about being isolated, and the problems about dealing with shame. And so it affects so much relationships because as it's so hard to get integration with the environment, they try to control the environment and other persons. So it's really hard sometimes to get relationships if you are trying to control people, because they suffer about not getting the cues properly. They may misinterpret some situations that are trying to be nice with them as like threatening. It's really hard. Everyone here who tries to treat a patient sometimes knows you're sometimes trying to help and these actions are misinterpreted because they are dissociated. And these problems of information processing and emotional dysregulation may cause very, very burden to form relationships. We have many information about dissociation in adults with BPD. The MSAD studies, we have like a paper with 8 years of following these patients, and we can see that patients with borderline personality disorder they have high levels of dissociation. And all other works from the literature demonstrated very clearly that in adults, high levels of dissociation have a very high association with suicidal behaviors and self-harm. And you have like a comorbidity very high with PTSD. And you have behavioral discontrol because it's really hard to act effectively in the environment if you are dissociated. Martin Borges has a very important paper that he showed that high levels of dissociation predicts poor DBT treatment response in patients with BPD. And all other papers show that patients with high levels of dissociation, they use a lot the medical system for long periods of time. When we talk about adolescents with BPD, there's a paucity of studies detailing the dissociative symptoms in adolescents with BPD. We have just very small studies. Most of them don't use the DES scale. That's the most famous way of assessing dissociative symptoms in this population. And so it's really hard to understand how this works in adolescents with BPD. So to fill this gap, we try to assess the severity and the quality of dissociative symptoms reported by adolescents with BPD. They were inpatients, both at McLean and Mount Sinai. And we try to compare these symptoms, both with adolescents without BPD and adults with BPD. So we took our data from the MSCAD study. In this study, we enrolled children from 13 to 17 years old. And also, we take data from the MSCAD that select adults from 18 to 35 years. Here, it's a very important point to make a diagnosis of BPD in adolescent. It was necessary for them to be both positive in D-bar and the childhood interview for BPD. The childhood interview for BPD is the only federalized measure to access borderline diagnosis in adolescents. We use the data from the diagnostic from the DSM and try to adapt it to children, and has like very good internal consistency and interventor reliability. So it's a very important way. Sometimes it's really hard to tell if a adolescent patient is borderline or not. You have to take care in using proper ways of diagnosing these patients. And also use the dissociative experience scales for calculating the severity and the quality of these dissociative symptoms. The D-bar is a very important measure. Mary Zanarini talked in this morning. For having the diagnosis of borderline, a patient must have symptoms for all these four sectors of the D-bar. So for affects and cognitions, we have like 2 points. And for impulsivity, 0 to 3, and interpersonal relationships, 0 to 3. So the patient must achieve 8 points to have the diagnosis. So we get like a very rigorous way to diagnose this population. That's a very important thing about diagnosing adolescents with BPD. Also, we use for studying the dissociative symptoms, the DES, that's a self-report that has like 28 items. They ask the percentage of how much percent of your time do you have like symptoms of absorption, amnesia, depersonalization, and overall severity. When we look at this data, patients who have like very low levels of dissociation, they score about 10. And patients with very high levels, they score about 30 or more. Patients with that score 30 points or more, most of them, they have like PTSD or dissociative identity disorder. Generally, you'll see here, we'll show the data about the overall score about dissociative symptoms in patients with borderline. So when we use the demographics, we use the analysis to study how this population, about the age, we saw differences in our healthy adolescents and your BPD adolescents. The difference about age is not that big, but it was significant, so it was necessary to do statistics considering it. And When you look about gender and ethnicity, we see that we didn't have any difference from adolescents with BPD and without BPD, but we have difference. Most of our patients from adolescents with BPD and healthy adolescents, they were female. And when we look at the percentage of white people, 87% of the people with BPD, they were white, the adult ones. So we have also to use linear regression to take care of this, to not compromise our analysis. So let's talk about the symptoms. When you use the DS, you have like the overall score, and you have like 3 factors that you study about which kind of symptoms these patients have, because for each symptom, there is a specific way to treat these patients and to help them. So when we talk about absorption, some questions about the DSS was like, was that a dream or did that really happen? I lose the sense of time in my thoughts. What happens in absorption? The patient gets so focused in some of their thoughts, or so focused on something outside of them, they lose the capacity of analyzing the environment properly. And this can be really harmful for interpersonal relationships and to get emotional regulation. When you see our score here, we have like score of 27 for adolescents and 21 for adults. They were the same. And low scores for patients, adolescents without psychiatric diagnosis. It's a really important thing because sometimes people think that absorption is a normal thing, like you are reading a book and you are normal, you don't have any problem. But when you talk about dissociative absorption, imagine someone who keeps imagining things in their minds and keep disconnected to reality. How hard it is to create social bonds. That's a really big problem. Depersonalization and derealization, they are also very important symptoms, and they are very associated with self-harm. And when you use this scale, some patients, they agree that they feel like seeing themselves from outside of their bodies, like not recognizing their hands, or look at the environment and see like a fog, like a very weird thing, and people appear very far and unclear. Imagine the suffering of persons who have like this 20% of the time. That would be really tough. So when we compare adolescents to adults with borderline personality disorder, they have the same prevalence. And look, the difference, 2% of the time the healthy adolescents suffer from depersonalization and dissociation. So this is a very distinctive feature of BPD and other dissociative disorder that damage and hamper social interactions. Amnesia. That's a really important point because here we are not talking about forgetting some keys and forgetting to give like a gift for your kid when he gets a birthday. It's something very, very terrible for these persons because imagine when you talk about with these adolescents or adults with very high levels of amnesia, it's really hard to get like a biographical medical history of these patients to understand how his life was developed because they have like many blank spaces. They can't remember many things from the past. And the more they suffer, the more it's harder for them to get information. This can compromise overall achievements in schooling and work. And we can see here that adolescents and adults with BPD have higher scores on amnesia as well. When you look about overall severity, we can see that the healthy adolescents, they score 9, and the adolescents and adults score around 20. They are really close to each other, this overall severity of symptoms, both in adolescents and adults. Here I think there's a very interesting data with very important clinical implications. The DS score gives us, when we divide by the score, a way of measuring the severity of these symptoms. And we see that this patient, they have like similar distribution, the adolescents with BPD and the adults with BPD. And one point that's surprising when we read about, our group had published about child neglect and sexual abuse and PTSD. Christina Temis published a really good paper in the Personal Mental Health. We should read it. It's a very important point. The incidence of PTSD is about 22%, even in the most severe dissociated group. And for adults with BPD that have like very severe ways, very severe scores in the DS, it's around 90% of these persons had like a history of child sexual abuse or PTSD. Why is this so relevant? Because most of the adolescents who have very high levels of dissociative symptoms, they don't report sexual abuse or PTSD. A possibility for that's to be underreported, but I believe, in my opinion, it's hard because most of these patients got very good treatments and they were inpatients, and when you are inpatient, you are asked about everything in your life. But when we think about the development of the adolescent brain, we are the prefrontal cortex, the last region to get ready, the last region to develop. So we have like the pruning, the brain pruning. So it's really hard, it's more common dissociative features in this population. So we used to think about, if in adults with BPD, I will ask about PTSD and sexual abuse. And I know that they will have like very high scores of dissociative features. In adolescents, if you do that, you might lose the opportunity of treating these patients, because a patient who has like levels of more than 30 in the DS for this disease, it's really hard for them to learn. So you have to be really focused about treating the dissociation of these patients. So we can conclude that our adolescents with BPD, they have high levels of all subscales of DS and the total score when we compare to developing adolescents. And when you talk about adults, they are almost the same. This has very important clinical implications. When you think about treatment, what I have to do with patients with high levels of dissociative disorder? The first point is not to be dissociated together with them. So it's important to have like good night of sleep, eat well, because if you're not focused in this concept, in this relationship with the patient, they will dissociate it too. Because patients learn by example. If you are not there, if you're not connected to this person, they won't learn anything with you. When you think about the strategies, we can use like cognitive analytic therapy that increases awareness about dissociation, about understand their mind status. So this might be very helpful for dissociation. When we use DBT, sometimes we target dissociation as a therapy interfering behavior, and we do chain analysis to understand how it works and how to deal with it. I really like the approach about MBT for dissociation. Fonagy has many good works about the importance of ostensive cues in the communication. When you are talking to someone, a patient, adolescent, mostly with BPD, you must look at their eyes. You must have like real conversations. You have to talk not about your mind. You have to talk in a way that they can understand that's relevant for them. Otherwise, these patients will dissociate during your conversation with them. So this is a really important point. When you think about good psychiatric management, we focus a lot about case management and psychoeducation. So we invest lots of time doing psychoeducation, explaining the dissociative features, and helping them to search at the internet how to deal with dissociation. So it's a way of helping the patients to have like accountability to treat their own symptoms. That's a really important point from GPM, to develop autonomy. Other thing that's important in the literature, naltrexone has some works for dissociative symptoms, but it's very inconclusive, the data. Another point that's really important is to see if the patient has like a trait of dissociation, which means like this patient has like dissociation all the time, or if they have like a state dissociation, that way of getting dissociated after getting some emotional vulnerability or stress. When you have things like that, it's really important to differentiate things, because if this patient has like a trait of dissociation, the most important thing is about using the ABC from DBT, like accumulating positive experiences and building mastery and coping ahead. That's a very important strategies. It's really important to help these patients to understand the consequences of the drug use in this population, because drugs really help to dissociate, the consequence of that. The importance of getting sleep, that's really important for dissociation. Also, when you think about distress tolerance skills for patients who have like a trait of dissociation, you have to work with them about accepting the reality that their brain has like this trick that under suffering, they are prone to disconnect. And this is really important because patients, when they are suffering, they are trying to control themselves, and the more they try to control themselves, the more energy they use on absorption, and the worse will be their outcome. So when a patient has these symptoms, we try to help these patients to understand that's really important to look at these behaviors without judging and try to direct their minds to pleasant things. And finally, when the patient like is in a really high stress, in depersonalization or very high levels of dissociation, using like tip skills like temperature, like ice packs is really important. Chili food is really important. In my office, I also always have like icy packs and pepper for helping these patients to be connected with them, because otherwise you are doing a conversation with someone who is like, it doesn't work at all. So you must work to have this patient connected to you. And you can use mindfulness to help these people about doing mind-body scan, to help them to get aware of their body, to deal like for derealization and things like that. And safety planning is very, very important, because if this patient gets mastery about dealing with these symptoms, this will be really helpful. So when we take this data together, these studies suggest that adolescents have dissociative experience as severe as adults with BPD. And to be effective with this patient, we should screen about the dissociative levels using the DS. Is really fast. They take like in 5-10 minutes, they can feel this DS score. And it's important to monitor this score and use a specific treatment approach for dealing with it. Thank you.